was gonna look at the schedule first for where we sit with regard to cruising toward the finish here, all right? We're in, the last part of week 11, so you got 12, 13, 14, 15, 16, 17. So we're, lab 7 nervous system, lab 8 reflexes, lab 9 special senses. Those are gonna come at you hard and fast the next 3 weeks, next 3 Mondays here. And then we do lab exam 3, and we get into essentially exam week here. We have, or the end here, we have lab exam 3, we have the Thanksgiving recess, we have the cumulative lab final, and then we have the cumulative lecture final exam. So it comes at you really, kind of slam dunk here. So you need to keep the pressure on. Don't think this is a, kind of an easy time to glide before we get to that tough stuff there. It's not a good plan. I would really encourage you to just stick with it, guys. We're past the halfway point right now. We've got lecture exam 2 and lab exam 2 that are, behind you at this point. And we'll go over the lecture exam toward the end of the session here today, but right now let's get on to this. How many of you have been heard about right brain, left brain? I don't have any notes on this. There's no notes on this piece right here. It's just fly through it on some things. You heard about that? Do you know if you're right or left brain? Do you know what the significance of that is?
One's like calculated and one's like artistic.
Huh. Yeah, one is, we usually say, we hear about something more logical, okay, that type of thing, more calculating, more logical, stuff like this. So we see illustrations like this. Look at all the color on the right side and kind of dull on the left. Okay, and so we think in terms of I'm left brain and logical and analytical and accurate, very numerically driven type stuff. This is the science. This is the scientist. This is the mathematician, okay? Or are you over here? The artistic, passion, creative, yearning, peace, all that, right brain, intuitive. Or are you whole brain, which means what?
A little bit of both.
A pairing of both. We would hope that there's probably some of that, but people have drawn all kinds of illustrations and made all kind of comments about it. And there's always a question: is there some real science or is there pseudoscience? Are you good with pseudoscience? Pseudoscience meaning what? So I think you told me you were a Libra or something like that. Isn't that right? I'm a Taurus, so that's we kind of gel, That's real science, right? No, it's pseudoscience. Okay, so the thing about it is we're not real certain as to whether this has a lot of clinical significance, if it has a whole lot of, if there's really a lot of science substance behind it at all. But nonetheless, people like that consider that's it. And some people really play into it heavily. Oh, I'm very right-brained. And so, I can't figure that out. Putting that puzzle together or figuring out how the mechanics of that automobile work, that's well beyond my pay grade. I'm right-brained, I'm not left-brained. So, whatever, you're just being introduced to it here, okay? If you haven't heard it before, if you haven't taken a psych class where they talk about right brain, left brain, and things like that, if you haven't been in an artistic class, we say, well, wow, really right-brain people over here, so left and right, okay? There's just some interesting things about, this whole concept of being right or left brain, and it's an exposure here, okay? Is there some legitimacy to it? Do you feel that you lean heavily one way or the other like that? We do talk in terms of, as I mentioned, right side controls the left side, right? Left side controls the right side of the body. So we'll keep that in mind as well. Let's go through some things here with regard to this. Okay, just merely an introduction to that. You probably have heard it before, but maybe not. I want to deal with, you have the chapter 13 brainwave and patterns for EEG. We're going to do that piece first before we go into the notes that you have. Some heavy duty stuff here. A lot of testable material right here, okay? So you should have picked up the packet back there, that was the one on brainwave patterns in EEG. Should be on your, should be posted to the Canvas as well. All right, so let's take a look at this. We talk about brainwave patterns EEG. You see this on any time you've watched a program where there is someone being hooked up, they got the electrodes and they're monitoring their, I guess their behavior. You need to pick up notes back there. All right, so we talk about EEG, electroencephalography, or electroencephalogram. Okay, so we're dealing with something which is recording the electrical activity that accompanies your brain function. We've already talked about millivolts, all right, with regard to communication of action potentials. Does that sound familiar to anybody? Please, help me out. Does that sound familiar? We're talking about millivolts and we're dealing with some electrical activity right here. So when we talk about an EEG electroencephalograph, if you're working in any type of an environment where we're dealing with a person in, let's say for instance, they're in critical care and you know, they've had some serious trauma, something like that, specifically if it's head injury or something like that, they're probably hooked up some kind of electrodes here. And so we're going to measure the electrical potential difference between various cortical areas. And so we see these electrodes that would be placed on a person like this, and we're going to talk about alpha waves, beta waves, theta waves, and delta waves. As I mentioned, this is all testable material, so I'd encourage you to pay some particular attention. So you should be here, you should be on this chart someplace. If we put some electrodes on you right now, you should be able to identify, I'm right there, okay? One of those four should be something you'd respond to. And hopefully it's not delta, okay? You're alert, you're awake, you're here. You know, lights are on. Looks like there's some activity going on. Okay, so you should find yourself in here. Hopefully not theta. Okay, so we can rule out theta and delta right now, okay? So where are you? You're gonna have to be, hopefully you're in an alpha or beta wave mode right now, correct? If we were putting some kind of electrode and have this EEG on you, we'd find that, are you alpha or are you beta? What do you think? Where would you find yourself on this scale right now? Someplace in between. Awake but relaxed? Awake and alert. Hopefully we're finding that most of you right now would register into beta. Would that be okay? Would that be fair to say that beta is where you'd like to have you? You're registering what's going on, you know, you're tuned into what's taking place here. Okay. So we talk about beta waves, is that awake and alert state, and it has these little squiggles on here that are supposed to mean something for, you know, anybody who's looking for pathologies or they're looking for interpretation of this, and we say, but notice that here's where I have a problem with this. What's the difference between this one and this one? I can see a distinct difference between these two, but these two right here kind of leave me a little bit challenged by, it looks very subjective. Are we good at the term subjective? Okay. So it would just say, well, yeah, they're in alpha. No, and this other one's going to argue, no, they're in beta. No, they're in alpha. No, they're in beta. Okay, so it appears to be that. So let's look at what's going on. Patterns of neuronal electrical activity. That's what the EEG is all about here. Generated by synaptic activity. Where?
Cortex.
Cortex. Where's the cortex? Remember that little 3 millimeter little skin, bark, cortical area overlying the outer covering of the brain there, okay? The outermost neurological covering on the brain is called the cortex. So we're talking about synaptic activity. Are we good at the term synaptic activity? That has to mean something when we deal with that. We got some kind of communication that's taking place there at that level in the cortex. 3 millimeters, you know, that little thin skin called cortex, aka bark, you know, here. Each person's brain waves are unique. That seems to make it even more subjective then, in my opinion. I'm giving you my opinion on this particular little piece right here. When we look at those waves and we say, okay, if each person's brain waves are unique, and we look at this, and we say, I can see a distinct difference between theta and delta, but I'm a little puzzled by the uniqueness of, that looks like maybe those are a little tighter or something like that. All right, so, can be grouped into 4 classes based on the frequency measured in hertz. You need to know this part. Hertz, cycles per second. Hz is cycles per second. Okay, are we good with that? How many times is this blip on here in a second? How many cycles per second? So we have beta, alpha, theta, and delta. All right, waves will be recorded as hertz, H-E-R-T-Z, that's like the car rental place, okay? Hz is the abbreviation word, and that references something which we say is, how many of these little cycles in there are taking place per second? Okay, so the beta waves. Here's the way I'd encourage you to remember this. We're looking at 14 to 30. Okay, 14 to 30 cycles per second. Rhythmic. Are we good with rhythmic? Okay? Or you got no rhythm. Okay? Rhythmic. Less regular waves occurring when you're mentally alert. It's rhythmic, but there's less regular waves occurring when you're mentally alert. The alpha waves, notice this. We've jumped down, we're now here 14 to 30, here's our top end right here, our 30, 14 to 30, and then we're at 18 to 13. So we're gonna plug in right behind this, okay? Or just ahead of that, let's put it that way. We're gonna plug in just ahead of the 14. We're gonna have 8 to 13 cycles per second. Cycles per second referenced hertz, right? How many hertz is it? 8 to 13. These are regular and rhythmic. Low amplitude. Amplitude means the height of them. How high are they going or how low are they going here? Low amplitude. They're synchronous waves indicating idling. When you're in park with your automobile, okay? Are we good? Are you following me on this? You got a car and doesn't matter if it's manual or automatic transmission. When you're not driving, you're gonna be stopped and the car's idling, okay? Is it running? Sure. Are you able to speed up? Sure. Okay, but it's idling. It's running, but you're not engaged in moving necessarily. So it's an idling brain. That's our alpha waves. I think we talked about, we should be here, right? Hopefully you guys are roped in at this one right here. We're in beta. You're not in alpha, you're not idling. That idling would be, hello, Tim, are you with me? And Tim would say, huh? Okay?
Yeah.
Tim's just got off a 12-hour shift, and so Tim
not
is
going
trying to get out of idle right now, okay?
Mm-hmm.
All right, so he's bouncing between alpha and beta right now, okay? He's gonna have to go, okay, Tim, it's okay. That's why he sits in front.
Exactly.
All right, so, are we following this? Is this making any sense? All right, so theta waves. Notice what we've done. We put this now in front of this. Are you following me on this? Okay, so here we have 14 to 30. This is our high end. We're gonna go here, put that in front of that. We're gonna take this, we're gonna put it in front of this now. Theta waves. What's going on here? These are really irregular, but we report them to be common in children. And why might that be? Maybe they don't have as much material up there they're concerned about right now. They got very few responsibilities. Do you follow what I'm talking about? We don't have to get really engaged in a whole lot of, quadratic equations and figuring out, the state of the financial situation in the world. Are you following me? We don't have a whole lot of material we have to deal with right now. We're dealing on very basic. Did you take my peanut butter cookies? Okay, and that's that's the biggest concern they have in the world for today, right now, okay? All right, common in children, uncommon in an awake adult. Yeah, we hope we're functioning a little bit higher level here with this. We're gonna plug in one more here. We're gonna put in delta waves. Where do we have these? We move these in front of these. Are you following what we're talking about? So in numerical order, we would say beta, alpha, theta, delta. Where should we find you if you're an alert and awake adult? we should have you firing up the max level, 14 to 30 cycles per second, hertz. If you're in deep sleep this evening, if you're really, buried in the pillow there, then we're gonna find high amplitude waves, okay? Ups and downs like this, deep sleep. And when reticular activating system is damped, as during, what's this?
Anesthesia.
What's that mean? You follow it? Anesthesia, what are you dealing with?
You're knocked out.
Knocked out. That's good, that's a common reference for you. Yeah, you got knocked out. You've been drugged. Surgical intervention or anesthetic, okay? You're trying to just calm your way down so that you're not really fully engaged in what's taking place here. However, if you are an adult, an awake adult, there's a real strong indication of brain damage. Something's been messed up here, okay? And that's why we see it when we talk about someone that's in, what would it be, intensive care? Automobile accident, they're in intensive care, they're going through some serious concerns right here. We're gonna be monitoring their brain activity, see what's going on. They're running delta waves, there's some issue going on here. Blunt trauma to the head, that type of thing, okay? All right, does this make sense? Beta, alpha, theta, delta. You're going from beta, it would be nice if it was A, B, C, D, but it's not, okay? For some reason, someone decided that beta should appear at the top of our alphabet in this numerical value, 14 to 30, 8 to 13, 4 to 7, and 4 or less. So we're gonna start here at our bottom, we're gonna say 4, 0 to 4, and then we're gonna go 4 to 7, and then we're going to 8 to 13, and then we're gonna go 14 to 30. Are you following what I'm talking? I'm trying to make it simple for you. That's the only way I can remember it, is just put it into a numerical platform right here, and say we start down here. Way to my left, that's the lowest value. That's the person who's, either been knocked out or brain damaged. Deep sleep, 3 different things we can look at. Your deep sleep, you've been knocked out with drugging, or you got some brain damage. That's where we're gonna start out here. And we get over here, and here you're fully functioning, alert, and kicking butt. Okay? Those are the two extremes on this side. You're good? All right, okay. So beta, alpha, theta, delta. Sleeping, minimum brain activity or brain dead here. They're using some different numbers here. Here we say state of deep relaxation, high creativity and insight. Subconscious mind, that's our theta. Allegedly, that's another interpretation. Okay. Notice what it says, uncommon in awake adult. This particular interpretation suggests maybe you're really ruminating about something, okay? You get up to this, and mind and body calm and relaxed, long-term memory activated, learning is easy and rapid. Okay, and then you get up here, and now we're talking mind and body active and busy, short-term memory being used. Okay? What looks like this. State of the brain. Your brain, my brain, our brains change with age. Sensory stimuli, brain disease, chemical states of the body, those can all impact the state of the brain here. EEGs used to diagnose and localize brain lesions. We could use them to identify if there's tumor activity, growth within the brain. Infarcts, that is to say if there's some kind of a, we talk about an infarct as being something where we have possibly a stroke type situation. There's some damage that's taking place there as a result of the absence of circulation to a particular area of the brain. We mentioned, last time we were here, I was mentioning to you about we could do a spinal tap or something. We want to find out is that if there's some symptomatic or sign presentation that this person has meningitis, or we suspect meningitis, is it bacterial or is it viral meningitis? Both of those can be seriously complicating. Well, that would be an infection that's going to be found in that cerebrospinal fluid when we do some type of assessment there. Abscesses. What's going on there? Is there some kind of a inflammation, infection or something that's contributing to something where there's some lesion in the brain here? But then we also have some epileptic possibilities that take place here as well. So it's not uncommon in our TV programming, if there's something like this with regard to an emergency room situation, we hear about, you hear this, and there's this flat line that takes place, either cardiac situation or in this case EEG function. We say it's flat, no electrical activity. And we make reference to its clinical evidence of brain death. Okay? Not a good sign. I mean, that's crisis situation. And there's no amount, according to what we know, there's no amount of CPR that's gonna bring you out of a flatline EEG. Okay? All right, so let's deal with some clinical factors that you've heard about. You probably, maybe you know somebody that has seizure activity, okay? What it amounts to is we say a victim of epilepsy may lose consciousness, okay, fall stiffly and have uncontrollable jerking activity. Epilepsy is not associated, did you get this? A person who's epileptic is not necessarily intellectually impaired. They're not people who are, less than as far as their neurological functioning. They have some glitches that are taking place that bring off the seizure activity. Epilepsy occurs in only about 1% of the population, okay? And so we talk about some of these individuals have what we refer to as auras. An aura is this sensory perception that something ain't right, okay? There's a glitch going on, and when an individual that has epilepsy has had a seizure like this, from that point on, they usually can tell, oh, that meant that I could have this loss of consciousness here. And so an astute individual, here, because they have a sense that this is going to precede a seizure, they may sit down, they may lie down, they may get themselves out of harm's way if at all possible, so that they don't impact others or even hurt themselves here. So the titles that I want you to be aware of are going to be this absence seizure. It used to be called petit mal. You heard about grand mal or petit mal. Those are archaic terms. You may still hear people use those, but they're trying to replace those with a reference to something called it's an absence seizure. Now think in terms of what that means. It's a mild seizure, typically found in young children. The expression goes blank for a few seconds. They don't get into the jerking, fall down motion like that. They just kind of, it's like they stepped away for a moment, okay, for a while. Do you follow what I'm talking about? It's just like they zone out, and you just say, and it's going to take maybe a few seconds to a few minutes before they're coming back again. But they don't have the typical, what we identify with the next expression here about that jerking motion, total loss of consciousness. These just, my understanding about this absent seizure is just that they're not there, okay? Tonic-clonic, which was the term back when I was sitting in your seats, we talked about grand mal seizures. When I was in the ambulance service, we talked about grand mal seizures. Okay, so a tonic-clonic seizure now is the one where we get all of this characteristic physical manifestation of someone who's having a severe seizure activity. These are the most severe. They can last a few minutes. The victim is going to lose consciousness. It's not uncommon for them, as a result of their flailing around or they're falling or coming in contact with furniture or other objects like that. Some of these people have experienced having broken bones, their convulsive activity, loss of bowel and bladder control, and there can be this severe biting of the tongue that takes place as well. So what do you do in this case like here? Let me give you a perspective on this concept from the standpoint of a person who's experienced this with a few people and worked on an ambulance service, okay? You don't try sticking anything in their mouth. You don't have to call 911, okay? All right? Some of these people can have seizures 2 or 3 times a week, all right? They can have a couple in a day in some cases in very severe situations. We don't have to call 911. You just wanna move things out of the way that they may be damaged by falling against or banging into. Clear the other people away. Try and keep, everybody's gonna have their phone out now and they're gonna be filming this whole thing about this person. Try and protect the dignity of these people. Did you follow what I just said? What's happening with them? In many cases, they lose bowel and bladder activity. What does that mean? They soil themselves, right? Try and protect their dignity. Anybody who's got a phone up, jam it up their, okay, I'm sorry. Just tell them, get the hell out of here. I'm gonna be real graphic about it. Put that thing away. This is another human being that's having a health concern right here. Leave them alone. Get out of their way. I mean, everybody is so willing to start dialing 911. They don't need 911 in most cases. That's an expensive situation for most of these people. And someone else has probably called 911 on them 2 or 3 times that month already. Do you follow what I'm talking about? In most cases, they just need to be given a few minutes to get themselves collected again. If there isn't any permanent damage, they may have been cut or bleeding or something. Well, maybe then they need to, go to the ER. But they can get there on their own. Yes.
How would you know the difference between a seizure and a stroke?
It's a good question. We're gonna get to that, okay? I'm glad you asked that, but we'll try and approach or respond to that question here. Do you follow what I'm talking about? Yes, sir.
Okay, so what about this versus like overdose?
Well, we're dealing with totally different circumstances like that. And that may, to your point, a stroke or an overdose or a seizure like this, people who have epileptic seizures oftentimes know they have experience of having had epileptic seizures. They probably aren't driving. They may be with somebody else, but the point about it is that can be an issue if, there usually are some indications, a person who's overdosed, facial expression, eyes and all the rest of it that go along with that. Some of you who've been around people who've maybe gotten a little bit alcohol or some recreational drug like that might be able, this type of behavior is uncharacteristic of people who've drugged. And typically, from my experience, it's uncharacteristic. When people on Quaaludes or people who are on, acid or things such as that, there was all kinds of real bizarre behavior. But this is uniquely of its own. They'll be perfectly normal, and all of a sudden they go into this thing. And over a course of, maybe less than a minute or so, they're having this jerking activity, and they don't need an ambulance. They don't need to have you jamming stuff in their mouth. If they do bite their tongue, okay, they probably have done it before. You're gonna bust teeth out of their mouth if you try jamming something in there. Leave them alone, give them some space, respect their dignity. They're probably gonna be, urinated all of themselves and ball activity on them, so try and just allow them to. Do you have some similar kind of protocols in the hospital?
Well, I suffered from a silent seizure.
From the first one, the absence?
Well, my neurologist called it silent.
Quiet?
Silent,
Silent.
yeah. 'Cause
I don't doubt that there's other terminologies for those, but I mean, when you're in the hospital setting, have they?
Yeah, I see it a lot.
Yeah.
I see it a lot sometimes, and then the oral, you get that feeling, and it's quick. Like as soon as you get the oral feel, that's what my neurologist told me. The feeling that I was getting, I didn't know what was going on with me. I just felt something weird. I knew it wasn't right, So she told me it's called the oral feeling. So like you said.
And that's my experience with having people tell me about that as well, where they, it comes on real quickly.
Yeah, real quick.
But
You're right. My doctor told me at one time, I guess when I had my girl trying to keep my hand from closing, and my neurologist told her, don't do it. Let it close.
yeah, leave them alone.
Just let it close and let it go. That's natural in you. It
And
takes
then
about a minute.
I'm sorry, I'm gonna ask another question. How long do your silent seizures usually?
It lasted, the very first time it lasted like a minute. About a minute. It don't go no more than about maybe 60 seconds, if that. It happens fast. Like the faster it happens, And once when I go into it, and then after a while, I just wake up out of it, like nothing happened to me.
Mhm.
So,
Yeah, and it has to be real confusing, is what the heck brought this on
Yeah.
up in this case. Okay,
Yeah.
you follow what I'm talking about? We're talking about, just try not to be too interventionist, you know, just try and leave them alone and assist if you are able to assist with whatever this might entail here, but don't try and be, you know, the big hero in the whole situation. I called 911. They don't need 911 in most cases, yes.
So you shouldn't call 911
No.
for a stranger that has a seizure
No.
and you don't know anything about them, unless they're like, quick
Under
leader.
most cases, they don't need that. Somebody's probably called in on them 3 times that month already, okay? They don't have to go to the emergency room in most cases. They're usually, they'll come out of it in a few minutes. They're exhausted in some cases, very fatigued from this, but within a matter of 5 to 10 minutes or so, they just have to try and figure out what they do with regard to if they need to clean up or anything like that, okay?
Okay,
In most cases, they don't need to go to the ER.
even if they're not known to be epileptic?
Even if they're a known epileptic, they
Not
don't.
known to be epileptic.
What?
Like if it's just like their first seizure, I guess.
Oh, if it's a first seizure, maybe they wanna figure out, but if it's, most cases, what we're dealing with is people who are, they might even have, medical alert band on them or something, or, have the chain on their neck or something like that, that's medical alert. But in most cases, just
So let it be.
let it go. And don't try filming it, this is not a filming, don't be Cecil B. DeMille here and figure you're gonna have this posted all over the internet. They do have some anticonvulsant drugs that some people who are known epileptics take. Vagal nerve stimulation or deep brain stimulation implanted devices have shown to be of some success. The vagus, what nerve are we talking about?
10,
What is it?
number 10.
Number 10. You all should have been jumping on that right away. Cranial nerve number 10, vagus. Okay, or directly to brain to stabilize brain activity. Research into brain electrode implants to detect and prevent oncoming seizures. Okay, I want you to remember corpus callosum. Did you hear that? I want you to remember corpus callosum. When we get to corpus callosum, I'm going to tell you something about epileptic seizure activity in corpus callosum. Okay? Consciousness. All right, are you conscious right now? We're supposed to be. Okay? Tim, no, Tim, you're okay. No, okay. It's your day again, Tim. Conscious perception of sensation. Voluntary initiation control of movements. When you are conscious, you're capable of voluntarily doing things, all right? So we talk about the capabilities associated with higher mental processing, memory, logic, judgment, things like that, are part of your activity when you are said to be conscious. All right, so loss of consciousness is a signal then that brain function is impaired, that we've got something goofed up going on here. So we talk about a couple of different ways in which that's interpreted. We say fainting or syncope. Fainting or syncope is this brief loss of consciousness. Not the same necessarily as these seizures activity, even the silent or the what was it? You said silent, no, absent seizure, there you go. Absence or silent seizures there. Fainting or syncope, a brief loss of consciousness, all right? Coma, now is an extended period. I can relate to having had an episode of fainting. I don't know if I've told you that episode at all, but I was on the playground when I had to be around 5th grade or something like that, 4th grade. I'm out in the playground, caught a ball, and the ball ripped my finger way back like this, okay? So, good Boy Scout, took 2 popsicle sticks, wrapped it up, bandaged it, everything like that. My finger was all bandaged up. And then I went home, my mother, all good with what took place there with me. And what happened to your finger? I had caught baseball or softball, whatever it was, and it ripped my finger back. I said, oh, cool. I mean, when you're one of 8, it's like, okay, it's just to stuff you under the rug and try and we'll figure it out later. I got more important things to do with these other 7. So at any rate, what it amounts to, the next day I go into the classroom, we actually had a school nurse in the building. My teacher, in her wisdom, says, oh, you should go down to the school nurse and have her take a look at that. Nurse Ratchet. If you ever saw One Flew Over the Cuckoo's Nest, you know what I'm talking about. Okay. I go into the nurse's office, she cuts my tape and my splint off, and she takes my finger and she does this. Boop, boop, I went boom, just like that, fainted on the spot. Should have gotten up and beat the crap out of that Nurse Ratched. Why would you do that? Didn't even ask me, does this hurt? She took my splint off, took my finger and went like this, and I just passed out. Bam! So the only time I've ever passed out. And I can remember it specifically about Nurse Ratched taking care of me like that. So fourth grader, you know, and I'm having my finger ripped back and forth. My splint was doing the job. There should have been a lawsuit. Can you believe that? To this day, all these years later, I still remember how Nurse Ratched took care of me. That wasn't her name. I don't know what her name was. She had, you know, that little nursing cap at the time like that. The white little uniform. I was laid out. They had, what, bunks or cots or things like that in the nurse's station. I must have been there for an hour, you know. Anyway, so she re-splinted my finger the way I had it. Extended period is a coma. So, clinically defined on continuum that grades behavior in response to the stimuli. Are you alert? You all should fit into this category here right now, okay? All alert, all right? How about drowsiness or lethargy? Can you relate to that? Just before I left to come here, my wife was taking a nap and I went up to her and I nudged her a little bit. Had a little piece of cake and some ice cream for her. And she said, and then she looked at me like, you know, the mole coming out of the ground at the springtime and just looking up like that, and a little drowsy. You've never been there, have you? Yeah, you know what I'm talking about? What would you call that? A little dopey, right, you know? Okay, drowsy, lethargy. You do that type of thing and I need a minute, okay? Can you relate?
In the morning, wake up, go to work.
Yeah, can you relate? Okay, yeah. You're not alert, you're in this stage where you're coming out of, why did you wake me? I was really in a deep sleep. Stupor. That's grading down. We're going downhill here. Do you understand what I'm talking about? We're going downhill. And then we get to coma. What was coma? Remember what coma was? An extended period of loss of consciousness, right? So, when we put this together right here, we say involves simultaneous activity of large cortical areas. When we're dealing with our alertness, we have large collection, a massive amount of these cortices that are synapsing in order to allow us to be alert here. Superimposed on other neural activities in order to have consciousness here. Holistic and totally interconnected, that is to say, all of these are firing and they're communicating with one another. Your nose, your eyes, your tactile sensations, all of those sensory receptors are working internally and externally. They're letting you perceive your world and keeping you on track with what's going on here, okay? All right, so we want to know about, this is going downhill, all right? As you start from here and you go downhill. Now, anybody know who Liam Neeson is? Liam Neeson, actor.
Yes.
I think the most recent movie, Stupid. I didn't see the movie. I don't know if I want to watch it, but was it Naked Gun
Oh, yeah,
the
yeah, I know
Second
what
or
it is.
something like that? I think is what it's
Yeah.
called right now.
Yeah.
Now he's the new main character of that goofiness there. I'm not recommending the movie. I haven't seen it. I saw a trailer and I think, I don't know if I want to go. But at any rate, I did to bring that up. I'm trying to remember why I brought that up. There's a brain fart that just took place right there. Maybe I'll figure it out in a minute here. I don't remember where I was going with that. All right. Sleep and sleep-wake cycle, state of partial unconsciousness from which a person can be aroused by stimulation. Like I mentioned, my wife was dozed off in the chair there. She was just reclined and she had just been out on a major shopping spree with her friend, neighborhood friend here. He was exhausted, poor thing. So at any rate, I woke her up and she's just real drowsy like that. So she was in this two major types of sleep defined as EEG, defined by the EEG patterns. Remember which one was going to be deep sleep?
Delta.
Delta.
What is it?
Delta.
Thank you. Delta. What was the brainwave cycles per second?
4
4 or less, 4 hertz or less.
4 or less, right? Is that right? Did I get that right? 4 or less cycles per second. You guys should have jumped on that right away. 4 or less cycles per second, okay? Defined by EEG here. But that's if it was deep sleep. Non-rapid eye movement, we say NREM sleep, and rapid eye movement sleep, REM sleep. Some of you who've taken psych classes have probably had some, tiptoeing through REM and non-REM sleep. I'm guessing that that would be accurate. Okay, sleep. Pass through first 2 stages of non-REM into stages 3 and 4, which is slow wave sleep they talk about. During the first 30 to 45 minutes, we get sleep here. Well, I think my wife's is probably in this 45 minutes where she'd already been knocked out there, right? All right, at about 90 minutes, after this 4th step, we get into what's called REM sleep. REM sleep begins rather abruptly, and there's really a fall-off. We'll see it on the chart that you have in your notes there. EEG, what's the EEG? Brainwave activity, the electroencephalogram, right? Electroencephalogram. Heart rate. Heart rate's gonna drop. Respiratory rate's gonna slow down. Blood pressure should drop. What is this GI motility?
So your gut
The gut. Motility meaning what?
movement?
The movement there, the processing. Don't we talk about parasympathetic and sympathetic? When you're sleeping, what should that be? You should be in sympathetic mode, right? Yes?
Calm,
You should be in which one then?
Para.
Para. You're supposed to be in para then, okay? Temporary paralysis takes place as well. That's kind of interesting, a paralysis. Okay, so here we see awake. Once again, here are these patterns here that we're talking about, which are rather subjective, in my opinion, based on that. I'm giving you my opinion. REM sleep, skeletal muscles, except the ocular muscles. What are ocular muscles?
Eye muscle.
Where are you gonna look for those? How many do you have?
3, the eye movements.
How many do you have?
6.
Is that a question or an answer?
Answer.
It's an answer. So how many ocular muscles?
6.
6. We have all those rectus muscles, superior, inferior, medial, and lateral rectus. We have superior oblique and inferior oblique, right? 6 muscles that control eye movement here, okay? All right, so it says here, ocular muscles and the diaphragm. Where are you going to find that? Between the thoracic and abdominal cavity there, right? Diaphragm. Are actively inhibited. Inhibited, we've already talked about inhibition, meaning what? Come on, guys, work with me. What's going on? Inhibition.
To stop.
Put the brakes on, right? We're inhibiting them. It says ocular muscles, skeletal muscles are actively inhibited, except the ocular muscles and the diaphragm. Most of our dreaming occurs here in the REM sleep. Most of your dreaming is a REM sleep event there. REM sleep is oftentimes linked to the fact that you're taking all that information from a day's experiences, and it's like your body is trying to find the file cabinet to put all this stuff in. Every one of those pieces of information that you had, we're going to put it into a document file in there. And that's what's going on. Non-REM, stage 1, non-REM, stage 2, non-REM, stage 3, non-REM, stage 4. Whew. Okay, relaxation begins, EEG shows alpha waves. What were the alpha waves? What was the wave pattern with those? What was the hertz cycle there?
Irregular.
Yeah, remember 14 to 30 was our high end? That was which one?
The beta
Beta
was,
waves.
the 14 to 30.
These are in the test, okay?
The 14 to 30 was the.
14 to 30 was the high end. That was the highest one, and that was which waves?
Beta.
The beta. Okay, so this says that you're an alpha wave. Alpha wave was, where was that? That was the second one down, right?
8 to 13.
8 to 13. We're gonna bookend it up against the beta wave here, okay, the alpha here. But notice what it says, shows alpha waves. Arousal is easy. What does that mean?
Can be woken up.
Yeah, no problem getting this person, they're not, we shouldn't have lethargy, we shouldn't have lethargy, shouldn't have the drowsiness, shouldn't be in that stupor situation. Wake up, boom, you're awake. Okay? Then we go to REM stage 2 here, excuse me, non-REM stage 2. Look at this, an irregular EEG. What they're talking about irregular, bam! Okay? Irregular. With sleep spindles, short, high amplitude bursts. Can be a little more difficult. Hey, wake up. Wake up. Wake up, okay? REM 3, sleep deepens, theta and delta appear vital signs decline. What does that mean, your vital signs decline? Dead? Heart rate, respiratory rate, okay, you got it? All this stuff is slowing down. You're really chilling here. And 4 EEG is dominated by the delta. Which were the delta?
It's the deepest.
What was the brainwave pattern there? What? How many cycles per second?
4
Four
hertz
less.
or less.
4 or less, right? Yes, ma'am.
So what kind of, like brain waves occur during REM, because it doesn't specify?
What kind of brainwave for what now?
For REM, like, cause I would have assumed that like the deepest one is the delta would have been during REM.
Well, they say here most dreaming occurs here, and they don't really put that into our pattern here at all. So I'm not real sure just yet, but we'll get to something here. Alternating cycles of sleep and wakefulness reflect natural circadian rhythms, 24-hour rhythm. You probably have heard of that before. You need to have a certain amount of sleep, right? You're supposed to have a certain, at your age, we usually talk about people your age here, 7 hours? No less than 6. You get older, you need less sleep. You're gonna talk about maybe your grandparents, something, 4 or 5 hours, I'm popped right awake. They probably sleep 2-hour nap during the day, but they, at night. I'm a nap person. I love taking a nap. I had about half hour. I usually have to have one before I come to this class, otherwise I fall asleep. I'm with Tim over here. We're sitting here checking for light leaks in our eyelids. All right, so RAS, what is RAS? Reticular activating system. Activity is inhibited during this sleep patterns here, but the RAS also mediates the sleep stages. The reticular activating system is responsible for kind of making this whole thing work here. Suprachiasmatic and preoptic nuclei of the hypothalamus time the sleep bacteria. You're going to learn a lot more about the hypothalamus next semester, right away in that first chapter of the endocrine system. The hypothalamus can come on smacking you in the head all the time there. If you want to get ready for 245, really pour into that endocrine system, because it's going to be coming at you hot and heavy at 245 there. Typical sleep pattern alternates between REM and non-REM sleep. This is what it looks like. You have that chart in your notes right there. We start here, you're awake. You drop into REM and you go down into these things right here, and then you pop back up, okay, into the REM sleep, and then you drop back down. Notice how as you, first hour, second hour, third hour, fourth hour, by the fourth hour here, you have a much longer period of REM sleep, and you don't go as deep into the stages here of non-REM sleep, the longer you are asleep. Okay? And then this REM sleep is considered to be so vital and so important. So when you have, for instance, classic example is new parents. Okay? And the baby is awake, every hour or so like that, and you're knocked out of sleep. You sleep for about an hour, you're down here, and all of a sudden you're right back up pure awake. And then you try getting back to sleep, and you've got this broken pattern of sleep as this child is fussing, or just having some problems. You got 2 or 3 kids like that, and you got confusion with the sleep patterns. It's a brutal time for a new parent in many cases, or a person who's having some kind of a chronic illness as well. It doesn't have to be a new parent, it could be a person that's dealing with some chronic illness. Okay, so you've been introduced to that stuff. There's a lot of material in there that's going to be testable stuff. That non-REM stuff, I'm not going to challenge you on that, but you need to know some of the basic information here. I'm asking you about the alpha, beta, delta, theta. Okay, you should know those pieces of information. They're going to be in the test. Okay. All right, so what do we have protecting the brain? You have the skull, we have the meninges, right? Do you remember what the meninges were? The meninges were what? Three of them.
Mother.
Three letters you should know there, D-A-P, right? Dura, arachnoid, pia, okay? Which is the deepest layer? Pia. Pia is the one that's most adherent to the exterior surface of the brain. Dura is the tough mother, the dura mater, tough, dura. Okay, the watery cushion, you're gonna have cerebrospinal fluid that's bathing the brain and allowing for some shock absorption capability within the brain. Anybody here ever been on a trampoline? Ever been on a rebounder? One of those little, stuff, things like that. If you ever gone to a rebounder, one of those rebounders, or you've been on a trampoline, the first few times you get on there, you say, oh my God, my head hurts, my brain hurts, it feels like it's slapping around inside it. But the longer you use that is to say, repetitively, if you do it a little while today and a little while tomorrow and a little while, pretty soon, it's the same thing for people who start running. You have to condition the whole body. And one of the things, that jostling or that bouncing or that slapping of the brain inside the cranial vault there, you have the stimulation of the watery surround there that helps to provide that cushioning effect. Okay, we talk about the blood-brain barrier. We've made reference to that with, wasn't it something about glial cells?
Mm-hmm.
Does anybody remember which were the glial cells that were responsible?
Astrocytes.
What is it?
Astrocytes.
Astrocytes. What was unique about the astrocytes? Most common, right? They wrap around the blood vessels in the brain there, and they perform this barrier. So they're going to allow for exclusion here. All right, meninx is another name you might hear people use regarding the meninges. We have those that cover and protect the central nervous system, protect the blood vessels, and enclose the venous sinuses. And the meninges are also those spaces, provide spaces there where we're going to have housing for the cerebrospinal fluid here. The meninges also form these partitions or these passages in that area. So we talk about three layers: the dura, the arachnoid, and the pia mater, as you were just mentioning here. The outermost to the innermost. And we talk about a homeostatic imbalance here. Itis is inflammation of, so we talk about if there's this inflammatory response here, it could be either viral or bacterial, then that can be problematic for the health of that area. And once again, whenever you have inflammation, you oftentimes have some swelling that takes place, and swelling within this area here. You have to consider, why is swelling important within the brain? Why might that prove to be problematic?
It's contained and there's nowhere for the swelling to go.
Good answer. A swelling can be space occupying, okay? It can compromise the available space. And so if swelling takes place, and there's supposed to be some capability with swelling where you have some expansion, well, if you can't expand out, but you've got some soft, cushy material in here, what are you going to do? It's like a sponge. What are you going to do? You're going to squeeze the sponge, right? Not good. Not healthy for your neural processing areas there. So here we see the stem, periosteum, bone. This is the skull. We have the dura. They make reference to dura in two layers. They say there's the layer closest to the bone, called the periosteal layer, and then there's the closest to the other meninges, and it's called the meningeal layer here. Okay? And so you have the dura as being separated into two factions. What do you need to know for testing purposes? Dura, okay? But you're going to find that histologists are going to separate it into an outermost layer and an innermost layer, and they're going to talk about this one as being the periosteal layer. What does that mean? It just means it's closest to the bone, okay? And what does the meningeal layer mean? Well, it's just, now it's the dura mater here. So we see the arachnoid, and the arachnoid is just this spider webbing material in here. And I like the way the artist interprets this in this case, because it almost looks like, do you ever see corrugated cardboard? Do you know what I'm talking about when I say corrugated cardboard? For those of you who are unschooled in corrugated, you know what? Okay. When you look at a piece of, we have a piece of cardboard right here, and then you look in the side of the cut piece of cardboard, and you're going to see that type of thing in there, okay? Corrugations. All right, what does that do? Well, it's supposed to make the cardboard, a little bit stronger. It's rather than just one layer. You've got two thin layers, but you got this stuff in here, so it, all right, so that's providing a space in there, and then that space is like this, like the arachnoid layer in here. And then you have the pia mater right here. Now, falx cerebri is this indentation going down the longitudinal fissure of the brain. The dura is the strongest, 2 layers of fibrous connective tissue around the brain separated to form venous sinuses. Sinuses are large spaces within the area of this tissue. The arachnoid, we talk about arachnoid kind of based on the arachno meaning kind of like spider webbing. So it's this web-like, separated by the subdural space. Subdural, sub meaning what? Below what?
Below
The
the
dura.
dura.
Yeah, deep to the dura. And then subarachnoid, now you're going to be in the area, and we're talking about the arachnoid layer, and it contains the cerebral spinal fluid and the largest blood vessels of the brain. I'm going to go back to the illustration here to see if we can pick that up here. They make reference to the, I'm sorry, here, subdural space, okay, subdural space, and subarachnoid space. So we're in the actual webbing here where we talk about subarachnoid, and here's the subdural. If this is the dura mater right here, the layer of the dura, these 2 layers here make the dura, then this space here, deep to the dura, but overriding this piece right here, we're going to say that's now the subarachnoid. All right, let's go here. Arachnoid villi protrude into the superior sagittal sinuses. Where would you look for something that's a superior sagittal sinus? Superior, forward, sagittal, what's sagittal? On the midnight, sinus is going to be an open space there, okay? Go back to that. Oops. We're talking about superior sagittal sinus. It's a space, it's a potential space created by the material here, kind of this separation of the dura. Here's the periosteal portion of the dura, and here's the meningeal layer of the dura. And then there's this space here. Well, the blue in there is indicating that that's deoxygenated blood, okay? Venous, when we hear about venous blood, when you get the term venous in there, you have to be thinking this is going to be deoxygenated. Deoxygenated blood, and in most cases in our textbooks, deoxygenated blood is colored blue. What is deoxygenated making reference to?
Without
Well, what would be the opposite of deoxygenated blood?
oxygenated.
Oxygenated blood. So when we talk in terms of the blood right here, we say oxygenated is going to be high in O2 and it's going to be low in CO2. Okay, oxygen. It's got a high. It's carrying a high concentration of oxygen and a low concentration of carbon dioxide. What is deoxygenated? Deoxygenated blood. How would you write the formula for that?
Low O2.
Okay, we're going to have low O2, and we're going to have an elevated level of CO2. The visual, consider the visual here. We're talking about low CO2, high CO2, high O2, low O2, deoxygenated. What color is the deoxygenated blood in most textbooks? It's blue. What color is the oxygenated blood in most textbooks?
Red.
It's identified as red. Are you going to be able to tell the difference between deoxygenated blood and oxygenated blood if you saw a puddle of it right in front of you here? No. Blood, it's red. It's just in reference to how we would, some might say, well, it looks a more robust red. It's a more ruby red as compared to a brighter red. Okay, fine. I've seen a lot of blood and I can't tell the difference between whether it's oxygenated or deoxygenated blood. We have to go with where it came from. Now, something that you will have, that you will be able to identify, here is a red vessel right here, here's a blue vessel right here that are providing some circulatory feed for the brain here. When you put your fingers on the side of your neck right here, can you feel a pulse there? Which pulse are you feeling for? What is it?
Carotid.
What is it?
Carotid.
Carotid artery.
Artery.
Now there's another vessel there, it's a jugular vein. How can you tell the difference? How do you know if you're not on, how do you know you're on the artery rather than on the vein?
Arteries,
Well,
veins
the
don't
artery
really
is spongy
pulse.
and the artery, you can feel the beat to it.
What did you just say?
So there's a pulse.
Arteries are pulsatile. It's coming right off of the heart here, we're getting a pulsatile. You don't feel a pulse in the vein. Okay, if you're on a jugular vein, so how would you know? I mean, it's gonna bleed, it's not gonna, if there's a bleeding from a vein, it usually just flows out. If there's bleeding from an artery that's fairly close to the heart, you're gonna have a kind of a spurting type of fluid emission from it. Did you understand what I just said? In reference to that, we usually say oxygenated is red and deoxygenated is blue. That's, pack that away for information for 245. You're gonna be tested on that again and again. In this case right here, we're looking at a sinus. We're looking at another area right here where there is blood moving through vessels that are considered venous sinuses. That's deoxygenated blood, okay? It's blood that's now gonna return back to the heart and then eventually goes back to the lungs to get oxygenated again, okay? All right, so the dura strongest, where are we here? I jumped, oops. Sagittal sinus and permits the CSF, the cerebral spinal fluid reabsorption here in that area. Pia is the deepest of the layers here, a delicate vascularized. What does that mean to say it's vascularized?
Contains
What?
blood vessels.
You got blood.
Yeah, it's got blood vessels. It's vascularized connective tissue that clings. I've made reference to it. I want you to understand what I said. You all should be familiar with saran wrap. You know, that film, saran wrap, it's like it's real shiny surface on the brain. When we get into the lab and we're doing the brain dissections here, oh, by the way, I got a note today. In reference to, we're gonna be doing, the first of our actual dissections takes place this week. We're gonna be doing the sheep brains. You gotta be, you know, the torn pants are not, can't wear those, have your shoes covered, have your, you know, arms covered, you're in the dissection, you need to have goggles here, all right? They're probably gonna be checking on us because it was a special note in an email I got today that says, we're now starting the dissections in the 244 lab. Make sure that your students are, okay? Adhere to those things I told you day one where they're being kind of, I don't know, it gave me the impression that we're gonna be observed. You know, that someone's gonna be coming and checking on us, okay? I just got the sense that that's new. Okay, all right? So please adhere to the instruction you were given at some point about that. Cerebral spinal fluid, the composition of it. You wanna go home and make a little bit tonight, get a little recipe here? Here's the recipe. Clear, colorless, watery solution formed from blood plasma. Did I do the blood plasma thing for you on the board here? Okay, a little bit of information before you get into blood work and 245, but it's important that we understand it here. Cleo, you know about this. When you draw blood from a person, right? What color is that? You pull the blood out from a person, it's red, right? But then you send it to the lab and they centrifuge it, and they spin the crap out of it, right? And what happens? We end up with 2 layers in here, actually 3. We have the top portion up here, we have the bottom portion here. This is plasma. And this is what's called formed elements. And this right here is commonly referred to as Buffy coat. Buffy coat is usually associated with white blood cells, leukocytes. L-E-U-K-O. The leukocytes are in this zone right here. The formed elements are going to be, this area right here is going to be red blood cells, RBCs, and platelets. Now, this is new CLC math. Follow me on this? This portion up here is 55%, which makes this portion down here, what, about 80%? What? New CLC math, come on, work it for me.
45.
What is it?
45.
Are you sure?
Yes.
This is new CLC math right here. Are you sure that's 45? What are we looking for here? We're looking for 100%, aren't we? So if the new CLC math would dictate that this is 100% of the blood sample, correct? Shouldn't have had to do that, but 45 and 55% right here. So 55% of the blood, when we draw it out of us, it's just totally fully red until we spin it out. And what's happening? Why did the formed elements go in here? They're heavier. This is all watery. This plasma is 90% water. Okay, did you understand what I said? 90% water. The formed elements are going to have our cellular material. The only true cells are the white blood cells. The red blood cells and the platelets are not true cells. Red blood cells don't have a nucleus. Platelets are just fragments of cells. Okay, so the only true cells are the white blood cells, which are generally considered to be, and it fits into this formed elements, but they're generally considered to be, what is this? What's that symbol right there usually mean? What is it? Less than? Less than 1%. So the white blood cells, the Buffy code, are usually considered to be less than 1% of the blood sample here. Okay, so less than 1% in the Buffy code are the white blood cells. But this, add those together with this, and that's generally in the neighborhood of 45% for all of that that's going on here. The plasma is what we're talking about right here, because the cerebrospinal fluid is derived from blood plasma. And what is blood plasma? Mostly what?
Mostly water.
90% water. Are we following what I'm talking about here? The blood plasma is 90% water. It's 55% of a blood sample. I don't care whether you just nicked yourself here and a little drop of blood falls on there, okay? 55% of that's going to be plasma and 45% is going to be formed elements. I don't care whether you have a bucket of blood. Fill that cup up with blood right there. It doesn't matter. What percentage is going to be? 55 what? Plasma, 45% formed elements. You follow what I'm talking about? Doesn't matter whether it's a droplet of blood or whether it's a whole vial of blood, or whether you got a whole, you've just given a pint. Okay? The percentages are plasma is 55, but 90% of that 55% is going to be water. It's mostly water. When we hear about having antibodies, when you hear about having gamma globulin, when you hear about those types of things, those are found within the plasma component. Where do we derive our cerebrospinal fluid from? It's a good question. Where's the cerebrospinal fluid derived from? It's on the board. Where is it derived from? The plasma. The cerebrospinal fluid is derived from the blood plasma. That wasn't a hard question. It was right out there.